My name is Valerie Osula. I'm one of the clinical instructors of emergency medicine at Hopkins. I'm also doing a global health fellowship, and I'm working with Bhakti Hansodi, who's the technical director in helping RISE support Rwanda for this international lecture series. We're going to have a great discussion today. We're going to be focusing in on mechanical ventilation and COVID-19, and we have some awesome speakers that I will go ahead and introduce. So we have Dr. Roy Brower here, who is the medical director of the ICU at Hopkins, and he will be giving us an evidence-based review on everything mechanical ventilation and COVID-19. And we also have our Rwandan colleagues from the clinical team. We have Dr. Appolinaire and Dr. Vincent, and they will be presenting a very interesting case on COVID-19 and mechanical ventilation. And so I want to welcome all of you to this series. For those of you who were able to attend our first inaugural one last year, thank you for joining us again. And hopefully it is just as entertaining and riveting. And of course, if any questions come up throughout the session, please definitely feel free to post them in the chat. I, along with some of my colleagues and Dr. Eugene and some of the rest of the team, will be monitoring and answering questions as we go along. There will be a dedicated question and answer period that we'll go through, but just want to make sure we open that up for everyone to feel free to have this be as much of an exchange of ideas as possible. And so welcome everybody. We'll get started. We've already introduced our topic for the day. This is our main objectives in terms of the RISE COVID-19 response in Rwanda and building capacity. And we want to thank our partners here, with both RBC and the Republic of Rwanda. And so our objectives for this talk here will be to discuss the clinical needs for early oxygen therapy for patients with COVID-19. Of course, discuss the needs for ventilation and highlight the appropriate settings that we need to manage these patients. And we'll get through all these objectives throughout the talk. The session outline, just so you have a bird's eye view of what should be happening. We're going to start with the case presentation. And then right after that, we're going to have an open discussion, a Q&A period. So feel free to put any questions in the chat and I will help moderate and facilitate that. Then Dr. Brower will give us his evidence-based review and then we'll wrap it up. And then that should be it. Hopefully we can keep to time as best as possible so we make sure we get everybody out of here within the hour. And so with that said, I'm going to pass it on to Dr. Appolinaire, who will go through our case. I'm going to stop sharing if you want to go ahead and share. And of course, we'll share all of our slides and all the information with our participants after the session.
Thank you, Valerie, for your introduction. As you said, I'm Dr. Appolinaire. I'm emergency physician at Paisal in Rwanda, and I'm a consultant in the RISE project for capacity building and the mentorship of district hospital regarding the management of COVID-19 patients. Can you press slides to see the case?
Dr. Apple, I'm happy to share slides. Would you prefer if I shared or did you want to share?
Yes, you can share.
Oh, sure, not a problem. Let me pull that right back up then. All right.
Yeah, the case I would like to present was a young male, 33 years old, who presented at emergency room with short of breath, fever, cough for 2 days. At arrival, the vitals were almost abnormal, except the blood pressure, where the saturation was 80%. There is someone who is disturbing. Can you mute Valerie, can you help to mute all people who are not with speech, and someone who is going to speak and raise their hands?
Yes, we'll make sure.
I've done that.
Okay, thank you.
Sorry about that.
The patient came unstable, except like for the blood pressure, which was 120/75. Respiratory rate was 25. Pulse was 110. Has have fever of 38.5 and the saturation of 80%. Next slide. As a history and examination of our patient, the symptoms was within 5 days, according to what he was saying. It started with dry cough, sore throat, and in the evening was having chills. As a background, he was working as a manager in the local supermarket. No drug, medical, surgical history. She reported smoking. But regarding the contact with someone who was positive, it was denied. But was under suspicion as someone who was working as a manager in the local supermarket where there are many people coming in and out. Next slide. On exam, the airway was patent. He can speak. He was tachypneic with the respiratory rate of 24-25. He was able to speak all sentences without breaks and no nasal trailing. Was tachycardic at 110 with the dehydration in the warm extremities. The Glasgow coma scales was 15 out of 15, and he was able, he doesn't have a neurological deficit. Next slide. Neurologically, cardiac, abdominal, and the locomotor system examination was normal. On the respiratory, he was having bilateral crackles, especially in lung bases. Next slide. Our differential diagnosis, first of all, thought about COVID-19 as long as there are like many people who were infected at the time. Bacterial pneumonia, malaria has having fever, and we can't neglect TB. Those are like was a differential diagnosis. Next slide about the laboratory. FBC, liver function, UND, CRP, malaria was requested in the chest radiography. Rapid test and the PCR for COVID was also tested. The rapid test immediately was positive, and later also the PCR was positive. Next slide. As the X-ray was showing mild bilateral patch area, lung opacity with peripheral and lower zone distribution in the anterior posterior, and the chest CT was showing ground glass opacities. Okay, the management as someone who was already confirmed the COVID-19 positive, the management started. Oxygen therapy was given at 8 liters per minute. As he was having fever, paracetamol was used. We started the ceftriaxone, azithromycin, dexamethasone, Levonox was given, omeprazole, and he was admitted in the COVID-19 treatment area. The next slide. On day 2 of admission, The patient SpO2 was 90 to 93, under 8 liters per minute without too much respiratory distress. As long as he was admitted under monitoring, on day 3, he was requiring high oxygen supplement with the Musgrave reservoir at 15 per liter, with SpO2 at 90%, the respiratory was 25. Day 4, even if he was on the Musgrave reservoir, he keeps having low SpO2 and the high respiratory rate at 33 and the saturation at 85. As long as he was not improving on that, he got intubated for respiratory failure, as long as he was not, the oxygenation and the ventilation was not good. Next slide. You can see on day 2, post-admission, the X-ray, how it looks like. You can see that on the right lung was more affected than left, and especially on the basal, you can see that there is opacities on, especially on left than right. Next slide. Before intubation, the X-ray which was done, you can see that it looks very abnormal, as it was not, oxygenation was not good, and the opacities in the lung was too much compared to day 2 post admission. Next slide. Okay, on clinical course of intubation, those are like the settings. He was put on the SIMV pressure control with tidal volume of 400. Respiratory rate was set at 20. The PEEP was 10 and the FiO2 at 100. And the vital signs was the BP 137/87. Pulse rate was 128, temperature 37, SpO2 88%, respiratory rate was 25, what he was making. He was sedated on intubation with ketamine, fentanyl, and midazolam. The arterial blood gas done was showing acidosis, pH of 7.2, with the partial oxygen at 60, pressure of CO2 35, bicarb at 20. Next slide. On day 2 post-intubation, the patient was worsening. There were like changes on ventilator, and the tidal volume was set at 450. Respiratory rate still at 20. PEEP was increased at 15. Pressure support at 18. FiO2 still at 100. The EBG done looks like abnormal, still abnormal, with pH of 7.5, PO2 of 51, PCO2 34, and the bicarb at 26.7. Next slide. On day 3 of intubation, he was still worsening on his condition. The PEEP was increased up to 20. Pressure support decreased at 15. FiO2 at 80. As you can see, still the patient was having hypoxia. The vecuronium was added to paralyze the patient so that it can be well ventilated. Next slide. On day 4, the patient had hypotension. Inotrop was used, norepinephrine with 6 micrograms per minute. But he passed away on day 5. He was failing. Inotrop didn't help to raise the blood pressure. Even if the ventilator settings tried, didn't help to oxygenate the patient. I think that's the case. We can have, those are like results. As you can see, it was done like at day 1, day 3, and day 7 of admission. And except on they didn't too much. CRP was increasing, as you can see. I think also he had the kidney injury. According to how the creatinine was rising, on electrolyte, there is not too much changes. Liver function also, it was, IST was increasing from 49, day 3 was 78, on day 7, 123. I think there are no other changes. Yeah. The next slide, I think that was the CT, chest CT on day 1 post-intubation. Then, as you can see, there are like too much opacities in both lungs, which was showing that he was developing ARDS. Next slide. That also is a CT, HRCT done on day 1 post-intubation. Maybe it's the same as the CT showed before. Yeah. Okay, thank you. If there is no questions, you may go to the questions session and answer so that we can have a common understanding and how we can manage well cases coming with COVID, so that we can save more people, even if they are coming at a late phase or with too much complications. Thank you.
Thank you so much, Dr. Appo. That was a great, and I'm sure difficult, challenging cases we've all faced throughout the pandemic. And I think we can start off by opening up the Q&A session. I'm going to look to you, Dr. Bauer, and we see these patients who come in and they're very difficult to manage on the vent. And, despite escalating therapies, they just, it's very hard oxygenating them, ventilating them, and kind of, I guess, now we're 2.5 years into the pandemic, right? And what are your lessons learned? What are your takeaways in terms of the best strategies for managing these difficult patients as they seem to decompensate from a respiratory standpoint on the ventilator? I think you're muted. Nope, still, you're on mute, Dr. Bauer.
Okay, can you hear me now?
Yes.
All right. First, thank you for including me in this discussion. That was a very difficult case, a good presentation, giving us a good flavor of the challenges. I'd like to ask the doctor who presented, is inhaled nitric oxide an option in your hospital? And was that considered in this patient? And then another question is about prone positioning. I think prone positioning, you showed a CT image of the patient. I think it was on day 1, and you could see the opacification is distributed primarily in the dorsal aspects of the lungs. If you turn that patient prone, there'll be more opacification in the ventral part of the lungs, but the ventral part of the lungs are narrow compared to the dorsal part, and so what you gain in aeration in the dorsal part of the lung will exceed what you lose in aeration in the ventral part. So those two things I think were worth considering if possible.
Dr. Vincent, do you want to speak to whether, those are options that you guys have used or employed in Rwanda, and what your experiences have been with proning or adjuncts such as inhaled nitric oxide?
Yeah, thank you very much. That is a really good question. During COVID, a lot of things has been tried, including the prone positioning. But also the big concern was about its efficacy. If you look onto the risk of extubation, remember those are the patient most of the time who get intubated, not because of altered mental status. They are patients who are awake, but after intubation, they have to be sedated just to, otherwise there would be asynchrony with the ventilation. So that was a really a big challenge of applying the prone position on the intubated patient because of risk of extubation. On top to that, those are really fragile patients. If it happens, they get extubated, the risk of succeeding the reintubation due to the severe hypoxia might take them before you succeed to intubate. I have seen a couple of patients who get this with this severe hypoxia. They are at risk of even like post-extubation, they are at risk of having a cardiac arrest. So this can be shown the way if you follow with the presentation. On day 2, if you can calculate the PO-FiO ratio, the patient was having a oxygen pressure of 60 on FiO2 of 100. On day 2, the patient was still dropping the pressure, the partial oxygen, dropping it to 54. So that's where we tried. There has been a starting of trying the RDS-net, whereby the FiO2 have declined to 80, and the people getting increased as per the RDS protocol. So regarding the nitric oxide inhalation, unfortunately, in most of settings, it was not available. But also, if you look on, maybe we shall discuss more for like evidence-based. It's all of trying. It won't delay intubation, and it hasn't really shown it to reverse the lung injury. The primary problems, as you might see, there was a severe opacification, and the obvious on the CT scan there is a obvious lung injury. So that was really a big limitation on which side to go according to the pattern of disease. That's what I can comment on that. Thank you.
Yeah, prone positioning is challenging. You mentioned the patients are agitated, delirious. There's something about COVID-19. Some patients with COVID-19, they become very agitated and they require a lot of sedation. And so sometimes they get neuromuscular blockade. Prone positioning is I think the biggest challenge to prone positioning is getting 5 people who are busy in other parts of the hospital to convene in one room at the same time. That seems to be the biggest challenge. But if you do it a few times, you get accustomed to it, and we have a protocol that gives assignments to each of the 4 or 5 people in the room. Hold the endotracheal tube, hold the chest tube, central line, and so on. If you get used to it, you can do it. And there's some evidence to say it will improve the outcomes. But I understand it is challenging for various reasons, including the ones you said. Dr. Vincent is muted.
Part of the challenge is, as you mentioned, is the staffing. So if you don't have like people to gather and control the proning, but also we have tried this procedure for awake intubation for the patient before they get intubated. But once they reach the level of intubation, this is really highly demanding in terms of staff and risk of safe extubation, and also like monitoring all of those patients. Thank you very much. That has been the main challenge, I think, most worldwide, not in our settings as well.
Definitely agree. Dr. David, did you have a question? I see your hand is up. Not sure. Maybe it's a mistake. If not, while you're gathering your thoughts, if you do have a question, I guess for you, Dr. Vincent, I think initially in the pandemic, we would try to stave off intubation and implement other strategies like non-invasive ventilation, such as BiPAP or high flow. And then I think at some point, maybe, I don't know, after the first wave or the second wave, we shifted to, a more aggressive early intubation strategy. And so I was just wondering what your practice, sorry, do you mind muting whoever is unmute? I was just wondering what your practice is now in terms of when you have these patients who, are decompensating from a respiratory standpoint. Is it early intubation? Is it trying things like high flow, BiPAP, awake proning? Are you maximizing those strategies and, kind of waiting for intubation as a last resort? What strategies are you seeing in Rwanda? And then Dr. Brower, you can comment on kind of what we're doing here.
Yeah, thank you very much. I would say that we have tried both options as the pandemic has been evolving. So the initial phase, back in 2020, when the COVID started, there was a literature supporting you just needed to delay intubation until the patient is getting the central hypoxia, where, with these delirious agitation. But also on my practice and the Rwandan protocol, later on, we realized that there's the prolonged hypoxia would lead to some of the organ injury. And that is typically manifested in this presentation. As you might see, the patient has been continuously deteriorating. And with the hypoxia, the patient end up having acute kidney injury, liver injury, and the cardiovascular compromise, which is marked by dizzy hypotension. So until now, the practice is recommended to initiate early intubation. Otherwise, the prolonged hypoxia will damage more the vital organs. So that is the current practice we have. Good enough. The pandemic is slowing down, but if any time we might have a case, that is the principle we might apply. And that's what I would advocate for. Thank you very much.
I think we've had a similar experience here. In the early part of the pandemic, in the year 2020, it was all new. We didn't know what to expect. And when somebody was worsening, we were inclined to intubate them earlier than we would otherwise have intubated a patient with pneumonia. One of the thoughts was, if you do it earlier, it's a more controlled situation. You can take more time to get your protective equipment on, take extra precautions and so on. Whereas if you wait too long and it becomes an emergency, it gets very messy. So in the early going, some patients got intubated early, but as we became more and more accustomed to the disease and more comfortable with it, we stopped doing early intubations. And now we will intubate a patient with COVID for the same indications as anybody else with severe pneumonia, namely worsening hypoxemia, work of breathing, use of accessory muscles, rising PCO2. But we don't do early intubations.
That'll be interesting. I'm sure Dr. Bauer, you'll give us more of the evidence behind all that in your talk. I don't know, Dr. David, if you did have a question, feel free to unmute yourself. Or if anyone has any other questions that they have, please post in the chat. I haven't been able to see. It looks like someone had asked about the ABG. Looks like initially the patient had a pH of 7.2 and then 7.5, but the PCO2 remained normal. I don't know if either of you can comment on, what the utility is in terms of trending these blood gases to predict possible need for intubation or, respiratory failure, or if they're tiring in your experience.
Maybe if I can comment on that, it's the compensatory mechanism of the patient. As I mentioned, the COVID pandemic has been associated with more affecting the respiratory system, where the central nervous system will be intact, leading to most of the patients trying to compensate themselves by increasing effort of breathing, tachypnea, which lead most of the time to some respiratory alkalosis due to this elimination of high CO2. However, if you look systematically the indication of intubation, I agree with Dr. Bauer, whereby we needed to look at the patient holistically. There is a main 4 indication. Let's say if the patient is having respiratory distress using the accessory muscle, responding to the lung injury, definitely that one needed to be supported. Otherwise, they will be compromised and fall in cardiac arrest. So I would say that the PCO2 dropping, leading to metabolic alkalosis, is more to the compensatory response of the human being. As you might see, the patient was young, 33 years old. I don't know, maybe for those who are more experienced, those are not typical pneumonia. People with, at this age having a pneumonia, dropping them down has been unusual, unless if for HIV positive for something like tuberculosis, that kind of pneumonia has not been usual. So he was trying to compensate. That's what I would comment on. Thank you.
Yeah, I agree with those comments. We use blood gases less now than we used to, but we use them first to validate the oxygen saturation measured by pulse oximetry. I think we tend to believe that value more than we should. Sometimes we get misled by an O2 saturation, and especially in patients with dark skin, we can be misled. So we want to make sure that there's a reasonable correlation between an arterial PO2 and the O2 saturation. And then we monitor PCO2 because if it starts rising, we're worried that a patient's breathing is failing. Some patients will maintain a PCO2 that's modestly elevated and be stable, but if it continues to rise and the acidosis worsens, then that's a strong point towards respiratory failure and the need for intubation.
Thank you both for your insights on that. Hopefully that answers your question, Rosemary. And I think we have time for just one last one before Dr. Bauer gives his talk. Looks like they're saying, I can see the patient has delayed intubation leading to deep hypoxia. I'm not sure if the intubation was specifically delayed, but and he presented with bilateral lung opacities. Are there any other medications, I guess, that you have had or used in your practice that's been associated to help support these patients who are being mechanically ventilated? I guess maybe speaking to adjuncts, kind of similar to inhaled nitric oxide. Are there any other therapies that you guys have employed that you found to be effective? Whether anecdotally or evidence-based?
Well, the patient got dexamethasone, which I agree with. I think there's good evidence for that. I think we probably would have used remdesivir in this patient. Is that available in your hospitals?
Okay,
It
the
has been
patient.
available at the latest stage, unfortunately. Go on, Apple.
Okay, that was what I want to say. This patient came like early, but later we have upgraded our management system, having those antiviral medication and some and the others anti-inflammatory drugs that as Tochi, which if they were there, we may have been used that. Unfortunately, we're not having those ones.
Mm-hmm.
All right, well, I think we've had a pretty good discussion so far in the interest of time. So we make sure Dr. Bauer gets to go over his case and his review. We'll continue to answer questions in the chat, but Dr. Bauer, if you wanted to, go ahead and get your slides up and take us through the evidence, go on from there.
Okay, so do you see my slides?
Yes, we see your slides. Perfect.
Yeah. All right. Well, thanks again for the invitation to join this discussion. It's good to be here. I'll try to get through this in 15 or 20 minutes, but there's a lot of evidence for mechanical ventilation in ARDS, and that's what this is mainly about, with a few variations on the theme specific to COVID. So here's a good image of a patient with COVID-19 pneumonia, predominantly interstitial and ground glass opacifications, propensity to be distributed peripherally. But this is just one phase of the disease. And of course, we have different patients with different responses to the same injury. And so we might see the same patient earlier on in his disease with much less opacification. Here is the image from the previous slide. And then another image, perhaps this is a patient with a more vigorous response to the injury, or perhaps this is the same patient later on in the disease. So again, this image in the upper right corner is typical for COVID-19, but there are many variations on the theme depending on who the patient is and at what point in the disease we encounter the patient. This is an important study focused on the differences in the lung mechanics and hypoxemia in patients with COVID-19 induced ARDS versus non-COVID-19 induced ARDS. So on the left, we have about 35 patients with COVID-19 ARDS in orange and 35 patients with non-COVID induced ARDS. And on the left panel, we're matched for the arterial PO, the P to F ratio. So for example, this patient might have the same P to F ratio as this patient. So matching for the P to F ratio, we look at respiratory system compliance, and it tends to be greater in the patients with COVID-19 induced ARDS. More compliance at the same level of hypoxemia. And this is a key observation, but I'd emphasize that there's a lot of overlap here, and so you can't make a broad sweeping generalization about all patients with COVID-19 induced ARDS. If we match according to compliance, the panel on the right, so for example, this patient has the same compliance as this patient, but we look at hypoxemia on the vertical axis, the patients with COVID-19 induced ARDS have worse hypoxemia. So to generalize, compliance tends to be higher, hypoxemia is worse, but those ranges are overlapping, and we have to be careful to avoid making generalizations. Right, so let's talk about lung protective ventilation in patients with ARDS with a few variations on the theme related to COVID-19. So we'll talk briefly on three topics here because we're limited in time. We could talk all day on this, But we'll talk about volume and pressure during inspiration. We'll talk about positive end expiratory pressure, setting PEEP, and prone positioning. I like to use this colorful image of lung volume on the vertical axis versus time. In the pink and red zones, we get ventilator-induced lung injury up here from overdistension. And down here, we get ventilator-induced lung injury from opening and closing. So ideally, we ventilate in this blue zone, avoiding those regions where we get ventilator-induced lung injury. So one thought is, let's avoid volume and pressure-induced lung injury here by using a lower tidal volume. And that idea was tested in the ARDS network clinical trial of traditional versus lower tidal volumes, published 22 years ago. And now it's changed clinical practice in many intensive care units. Tidal volumes used in that trial are illustrated here. These are in milliliters per kilogram of predicted body weight. 12 versus 6 milliliters per kilogram were the target tidal volumes. As I'm sure most of you know, the patients who received lower tidal volumes had better clinical outcomes, here mortality on the vertical axis, than those who received the traditional larger tidal volumes. So that protocol was very complicated, but it can be summarized simply here. The tidal volume goal is 6 milliliters per kilogram predicted body weight, predicted based on gender and height. But we reduced the tidal volume further if the inspiratory plateau pressure exceeded 30 centimeters of water. Some people interpreted this protocol rule to mean decrease the tidal volume until the plateau is below 30. No need to get any lower on the tidal volume once you're below 30, or use pressure control with an inspiratory pressure less than 30 centimeters of water. Behind this interpretation is an assumption that plateau pressures below 30 are safe, but we don't think they are. 30 was just a limit we had to use because we had to write a protocol. A normal plateau pressure in a patient without ARDS is about 5 or 6 centimeters of water. So plateau pressures of 28 or 30 are up there. Here's a graph of mortality rate versus plateau pressure on day 1 in that clinical trial of traditional versus lower tidal volumes. If plateau pressures below 30 were safe, we'd expect this line to level off like this, but instead it continues down. So we don't accept the idea that plateau pressures below 30 are all safe. We reject that interpretation. So the tidal volume goal is 6. There you see the equations we use for calculating predicted body weight. The inspiratory plateau pressure limit of 30 we still use, but if possible, we try to get the tidal volume even lower if it's tolerated to get the plateau pressure even lower than 28 or 29. And in patients with COVID, maybe there's an extra opportunity to do this because they have extra compliance. Their compliance tends to be higher than those with non-COVID induced ARDS. So at the same tidal volume, their plateau pressures may be lower. So the tidal volume goal is 6. If the plateau pressure is greater than 30, we decrease the tidal volume to 5 or to 4. So what about PEEP and FiO2? This table of PEEP and FiO2 settings was the table used in that tidal volume trial conducted by the ARDS network. The focus of that trial, of course, was tidal volume, but the investigators wanted to control how PEEP and FiO2 was used to avoid confounding. Perhaps some patients, one of the tidal volume groups would get a different level of PEEP and FiO2, and that would make interpretation of the study difficult. So each of these combinations of PEEP and FiO2 was developed by consensus. There was not a lot of evidence here, but the investigators who designed this table knew that too much oxygen could be oxygen toxic, and they knew that too much PEEP could cause circulatory depression and barotrauma or ventilator-induced lung injury from overdistension. Right? So maybe we should have used higher levels of PEEP in that trial. Some people said we should have. So if we use a higher level of PEEP, we can avoid ventilator-induced lung injury from opening and closing, but we run the risk of getting ventilator-induced lung injury from overdistension by pushing that peak volume there to higher levels. So to test this idea, we did another study. We compared two groups of patients. We divided patients into two study groups, one that got the traditional PEEP and higher FiO2, the lower PEEP and higher FiO2 table, and another study group that got higher PEEP with lower FiO2s is shown here. The separation in the PEEPs and FiO2s are shown here over the first 7 days, approximately 5 or 6 centimeters of water, higher in the higher PEEP group. But the differences in the mortality was not different between study groups. That was a disappointing result, but it's an important result. And it's been supported by subsequent studies of other approaches to comparing traditional to higher levels of PEEP. The Canadians did a study with 1,000 patients, the French with 767, and then a multi-center, multi-continent study called ART, over 1,000 patients. And here in this crude meta-analysis, you can see the mortality rates between study groups, higher versus lower PEEPs, are the same. So the idea that we should be using higher PEEP has not been supported by the evidence. When you use higher PEEP, you pay a price. We're trying to prevent ventilator-induced lung injury from opening and closing. We're trying to use lower FiO2s to prevent oxygen toxicity, but we pay a price. Decreased venous return, higher right ventricular afterload, ventilator-induced lung injury from overdistension. And in taking all patients as a whole, it appears that the price is not worth paying. On the other hand, some patients are PEEP responsive and some are not. This patient on the top, if we raise PEEP in this patient, we'll see a lot of recruitment and relatively a little overdistension. But the patient on the bottom experiences little recruitment when we raise the PEEP and a lot of overdistension. So maybe we should take these patients out of the study, randomize just these patients to traditional and higher levels of PEEP, and if we do that, maybe we will have identified the patients who get more benefit than harm out of higher PEEP. All right. The way I approach the setting of PEEP now is I start with the lower PEEP and FiO2 table, and then I measure the driving pressure being the inspiratory plateau pressure minus the PEEP. The driving pressure is a good indication of the stress in the lungs with each breath, and it's strongly associated with outcomes, as we know from this study in the New England Journal that showed the relative risk of death was higher when the driving pressure was higher. So I set the PEEP to maximize respiratory system compliance, which means with a constant tidal volume in the volume cycled mode, we're minimizing driving pressure. So after setting PEEP according to the lower PEEP table, I'll then adjust it by seeking the driving pressure, the lowest driving pressure. And in some patients, I do raise the PEEP, and in other patients, approximately 30%, I wind up lowering the PEEP to get to a lower driving pressure. Let's shift now to prone positioning. Here are CT images of the same patient in the supine and the prone positions. In the supine position, most of the opacification is in the dorsal part of the lungs. The ventral parts are better aerated. When we go prone, now we lose some aeration in the ventral part of the lungs, but we gain aeration in the dorsal parts. And because this part of the lung is wider than this part, what we gain here is more than we lose here. And oxygenation usually improves, right? The ProSiva study showed that clinical outcomes, as shown here in a survival curve, are better in patients who are prone. And so there's good evidence supporting this practice. We prone patients when the P to F ratio is below 200 and the PEEP is at least 10 centimeters of water. We try to keep patients prone for 16 hours a day or more. We turn supine once a day if necessary to examine, to service a catheter, and so on. Neuromuscular blockade is used frequently, but it's not necessary in some patients. We go supine when the P to F ratio is greater than 200 and the PEEP is less than 10. And we pay a little extra attention to enteral feeding in the prone position because there might be more regurgitation and potentially aspiration. I like to use this image just to remind myself that proning is not that easy. We talked about the challenges prone positioning earlier. You need to get 5 very busy people who have responsibilities in other parts of the hospital to converge in the same room at the same time and spend 15 or 20 minutes doing it safely. But it can be done, and once you get used to doing it, it's easier. All right, I think I'll finish here with this set of images. On the left, the image of the patient with COVID-19 induced pneumonia, and on the right, a patient with non-COVID pneumonia. Some differences in the distribution of the opacifications, some differences in the lung mechanics and the experience with hypoxemia, but more similarities than differences. We can use what we understand about the mechanics of COVID and the natural history of COVID to make some modifications to our traditional approach. But the traditional approach with lower peeps and lower tidal volumes is a good way to get started. And with that, I think I'll finish, and I thank you very much for your attention, and again, for the invitation to join this conversation.
Wow, thank you so much, Dr. Brower. That was pretty informative. I feel like I learned a lot myself, particularly about, I feel like they teach us so much about the plateau pressures. And so that was interesting to see that change. So I don't know if it's been adopted cross disciplines and, universally, but it'll be interesting to see, kind of what comes out after all the outcome studies from COVID and the things we've learned. So I am going to open it up if anyone had any questions for Dr. Brower, Dr. Vincent, Dr. Appo. There's a question in the chat. Okay, I think Dr. David was trying to comment earlier on the use. You'd asked about the use of inhaled nitric oxide and proning. Says that they had done that for many patients, but of course, as we've all mentioned, getting the number of staff to do that effectively and continuously is definitely challenging and is a big limitation for why they didn't employ it as much for their patients. Anyone have any other questions? Feel free to just unmute and ask or pop it in the chat.
So I think the question which was asked on the chat by Dr. Mukunzi Rosemary was about the compensatory mechanism based of the value. I tried to answer it on the chat, but I want to call upon her if maybe I didn't clarify the answer. For the acute setting of someone in respiratory failure, you may have normal bicap, while the compensatory mechanism is still being responded by respiratory system. And the big challenge also happened for COVID-19 because it was presenting with severe hypoxia without necessarily the compensation. So that's where you would be like someone being severely hypoxic, but with normal respiratory pattern, and without necessarily affecting the PCO2 and the bicap at the same time. Because like the compensation depends on how much the respiratory system has been exhausted. That's what I can comment on the question which has been provided in the chat. Thank you very much.
That clarifies things regarding the gas. I don't know if Dr. Brower, you had anything otherwise to add. Oh, Dr. Eugene has his hand up. Dr. Eugene, you can go ahead and unmute yourself.
Hello?
There we go. Hi.
Yes, I think, okay. So I wish to ask to my colleagues, David, Vincent, and Appolinaire. I think I will request during the next round of mentorship to create some scenario so people can understand better those mechanisms of compensation. I think all staff are not really comfortable. So people in ICU, they know, but other staff also need to understand to to understand the mechanism. So, but we can save time during mentorship and discuss with different colleagues about that. Have you got my point?
Yes, we did. In our mentorship, we try to approach people who are like treating patients, and we have like a wide discussion. When there is a patient in isolation, we do round together and discuss options for better management of patient. Maybe in the next round of mentorship will be creating scenarios and the more explanation on oxygenation, the ventilation, and those compensatory mechanism of patient with the either pneumonia, as the blower was saying, or in the COVID patient. Thank you.
Thank you.
Awesome. Thank you both. I mean, I think the point of these series is to kind of spur that discussion and knowledge exchange and, help all of us, across countries better manage our patients. So I want to thank everybody for your time. Thank you, Dr. Appo. Thank you, Dr. Vincent, Dr. David, and Dr. Brower. Give everybody back 4 minutes. We look forward to hosting you all again. Before, it's every 2 weeks. Our next session will be COVID-19 management in pregnancy. So definitely will be interesting. Hopefully you still have your link. We will be sending that out again with the flyer. We hope you'll be able to join us next time. I wish you all a lovely evening or day. Thank you again.
Thank you. Bye-bye, everybody.
Bye.
Thank you. Bye.